conference has been great at really dissecting the data and helping us learn from each other about how we're going to apply it in our practice. I think we're getting a rare conversation between experts, and that creates an opportunity to see how we view the same data differently, how we apply it differently, and absolutely, I came away last year with things I did differently in my practice because of conversations I had here. So I do think it's a very unique opportunity at this conference. So the panels tackle different topics, right? I think from the immunotherapy session, it's still all very developmental, but we're all interested to learn from each other about maybe trials we're not running, so the conversations between the session there almost. But for the radioligand, for instance, I think it's very, very helpful that we're all using this in practice, at least with the lutetium PSMA. There are newer ones to come, but the session on radioligand really allowed us to speak to each other and probe our reasoning for why we do certain things or how we think things should look in the future. Androgen deprivation therapy has always been the cornerstone, and it remains the cornerstone. If anything, the evolving role is really showing us that stronger androgen deprivation with doublet therapy is very, very beneficial to patients. In the future, our patients dream of a day when everything won't center on androgen deprivation therapy, but we'll have some other options because there are side effects. And so as our patients are living longer and we're using androgen deprivation therapy longer, we have to go back to our internal medicine roots and make sure we're taking care of patients as whole human beings, watching their cholesterol, the risk of diabetes, their bone density, so that they not only live longer, but they are healthier during that time. So androgen deprivation therapy use really hasn't changed despite all these new therapies that have come around, including radioligands and the stronger AR pathway inhibitors, because we're mostly layering them on top on the base of the castration or the testosterone lowering, which is ADT. With the one exception, I would say, I guess, of the EMBARK trial that was the first to really show ADT alone, ADT doublet with enzalutamide versus the enzalutamide alone, so that's like the first time we're not having ADT as the base, had some activity. It was somewhere in between the other two. So maybe we'll be seeing more of that, but it's hard to imagine that we'll completely get away from ADT since it almost seems to synergize with many of these new agents that we're developing.